The next session is Luncheon Seminar 1, sponsored by Eisai Company Limited and MSDKK. This session will be chaired by Dr. Naoya Kato. Dr. Kato, please.
Good afternoon, everyone. And I'd like to start Luncheon Seminar 1. And the theme of this Luncheon Seminar is the value of lenvatinib synthesized in Japan in patients with HCC, including harmonization with local regional therapy. And the first speaker is Professor Takeshi Terashima. And please refer to the page 64 of the abstract book. But briefly, I'd like to introduce him, and he is now Associate Professor at Advanced Preventive Medical Sciences Research Center, Kanazawa University. He has graduated from Kanazawa University School of Medicine 2003, and from 2018, he took this position. His topic is positioning of lenvatinib and role of adding hepatic arterial infusion chemotherapy to lenvatinib for unresectable hepatocellular carcinoma in era of immunotherapy. Professor Terashima, please.
Thank you for Professor Kato for nice, wonderful introduction. Good afternoon, everyone. I'm Takeshi Terashima from Kanazawa University. It's my great honor to talk about systemic chemotherapy for unresectable advanced hepatocellular carcinoma today. This is my COI. And please check the lenvatinib package insert carefully, and my presentation contains information on drugs not approved in Japan. As you know, recent development of systemic therapy for advanced HCC was remarkable. Although there have been many negative studies in the 10 years since sorafenib came into use, but treatment regimen has shown the usefulness as second-line treatment, and they are being used in clinical practice. Moreover, two immunotherapy regimens have also proven to improve patients' outcome and established as a standard of care in first-line treatment. Now, Japanese guidelines recommend combination therapies of atezolizumab plus bevacizumab or tremelimumab plus durvalumab as first choice for advanced HCC who had good performance status and preserved liver function and are unsuitable for local therapy. My given topic of today is the value of lenvatinib, including harmonization with local regional therapy. And then I will mainly share our clinical data about lenvatinib adding hepatic arterial infusion chemotherapy, HIC hike, using cisplatin in HCC. This is today's agenda. At first, I'd like to consider the positioning of lenvatinib in era that immunotherapies are first choice as first-line treatment for advanced HCC. I'd like to quickly share the information about clinical trials of lenvatinib for HCC. Following promising results from a phase 2 trial, a global phase 3 trial, REFLECT, which was open-label, multi-center, non-inferior trial to verify the efficacy and safety of lenvatinib compared to sorafenib, included unresectable HCC and no prior chemotherapy. So you know, this slide shows Kaplan-Meier plot of overall survival, primary endpoint of REFLECT study. OS is met to their non-inferiority hypothesis. The median OS of lenvatinib was 13.6 months. Median OS of sorafenib was 12.3 months, and hazard ratio was 0.92. Unlikely OS, PFS was statistically longer in lenvatinib group compared to that in sorafenib group. Median PFS of lenvatinib group is 7.4 months, and that of sorafenib group was 3.9 months, and hazard ratio was 0.66. Several reports have confirmed the safety and efficacy of lenvatinib also in clinical practice. But PFS was slightly shorter than those of REFLECT. It may be caused by the lenvatinib has been administered to patients in clinical practice with Child-Pugh class B, or the patient with previous systemic therapy who are excluded by REFLECT. Then, as you know, two immunotherapies has proven to improve OS compared to sorafenib. One is combination therapy of atezolizumab plus bevacizumab in INBRAVE 150, as shown in this slide. Another is combination therapy of tremelimumab plus durvalumab in Himalaya study. Himalaya also have shown the non-inferiority of durvalumab monotherapy compared to sorafenib, and then it is also one of the standard of care for advanced HCC. This is the efficacy summary of lenvatinib in REFLECT. In summary, treatment effects such as response rate, disease control rate, or progression-free survival of lenvatinib was superior to sorafenib, but OS was comparable to sorafenib. In contrast, response rate of combination immunotherapies was not so high, and PFS was comparable to lenvatinib. However, OS of immunotherapies were statistically longer than that of sorafenib. There are quite difficulties in comparing the efficacy result of different trials because of various biases, including significant differences in patient backgrounds or available treatment for subsequent therapies. In fact, this is a Kaplan-Meier curve drawing PFS and OS of advanced HCC patients who received two treatment regimens at our institutions. You may feel this is a strange and different result from a clinical trial. I would not intend to state that they have the same efficacy based on this result. For some reasons, I can't show this on the slide, but you all know how safe these treatments are. Most of you would consider the tolerability of lenvatinib appears to be inferior to that of immunotherapies. Based on these results, most of you would agree that I consider the primary positioning of lenvatinib is as a second-line therapy after immunotherapy since 2019. Now, let's move to today's main topic. Let me introduce the LEOPARD trial, a phase 2 trial, lenvatinib plus hike using cisplatin. The aim of LEOPARD trial was to evaluate the efficacy and safety of lenvatinib in combination with hike using cisplatin. The result of this study was published, written by Professor Ikeda a few months ago, so you can confirm more about it. Main eligible criteria included advanced HCC patients with any intrahepatic lesions, no prior systemic chemotherapy, and presence of major lesions. And this study included patients with Child-Pugh classification A at enrollment. A total 36 patients were enrolled in this study. and their background are present in these slides. Compared to clinical practice, the patients were slightly younger. Most of them had good performance status and good hepatic reserve. One third of the patients had undergone resection or percutaneous intervention, and half of them had undergone TACE as prior treatment. The characteristics of the study included 44% of the patients had vascular invasion, 64% had more than 5 tumors, and the median diameter of the longest tumor was 5.6 centimeter. Most of patients enrolled in the study are advanced and expected to receive additional effects of cisplatin. The result of primary endpoint, objective response rate, are very attractive. Among the 34 evaluable patients, the response rate assessed by an independent review committee according to the modified RECIST was 65%, and according to RECIST criteria was 46%. And PFS and OS were also favorable results. Median progression-free survival was 6.3 months, and median overall survival was 17.2 months. The combination therapy was reported to be well tolerable. Among the adverse events, the frequency of hematological toxicity, which may be caused by cisplatin, was high, but only around 20% of the events were grade 3 or higher. Although there were cases of worsening liver functional reserve, most were grade 2 or lower and reversible. As for renal function, the increase in creatinine, mainly due to cisplatin, worsened to grade 4 in one patient, but this figure was considered to be well tolerable, along with the protein characteristic of lenvatinib. Although fatigue, malaise, anorexia, hypertension were more frequent as symptoms, the frequency of grade 3 or higher was low and considered manageable compared to the administration of each of these drugs alone. In summary, the safety profile of LEPAD regimen is some of those of lenvatinib and cisplatin. They do not overlap, so they were well tolerable and manageable, I think. As you can see, these results of LEPAD were comparable to those of other regimens, and especially with regarding to objective response rates, lenvatinib plus cisplatin were superior to those of other regimens. Since the result of this study were obtained, we have tried this combination therapy in clinical practice and would like to share the results. Patient background of the 40 patients is shown in this slide. Most of them had good general condition and liver functional reserve, but Child-Pugh score was 7 in 28% of patients. 30 patients had been treated with immunotherapy as prior treatment. 38% had vascular invasion, and 25% had extrahepatic lesions. Best overall response based on RECIST were very high, as in the LEPAD trial, with a response rate 68%, including 4 cases of complete response and 23 cases of partial response. Also notably, no cases of progressive disease at 6 weeks. 6 weeks after treatment started were observed, and only 2 cases of PD at 12 weeks after treatment started, suggest a high tumor control rate. The median PFS and OS in this cohort were 8.8 months and 19.6 months respectively. Although it is not appropriate to simply compare these results, they are better than the median PFS of 6 months for lenvatinib monotherapy at our institution. So you can see most of cases in practice were treated after ICI immunotherapy, but in some cases with severe vascular invasion or high tumor burden, we sometimes administer the drugs in the first line prior to ICI if we want to expect a response. In case of large tumor sites, more than 10 tumors or vascular invasion, this therapy is often introduced instead of lenvatinib in our clinical practice. We have experienced CR cases after a certain period of observation and cases that are initially considered unresectable due to severe vascular invasion, but ended up with a conversion resection. Let me introduce some representative cases. Radiological examination revealed that huge HCC occupying the right lobes of liver in a 67-year-old man complaining abdominal fullness. We introduced lenvatinib plus hike using cisplatin to him in the hopes that it would shrink that more. When treatment was initiated, more blood flow decreased quickly, and the tumor began to shrink gradually. The tumor marker DCP also decreased markedly. The treatment effect continued for 1 year, but viable lesions appeared beside the tumor, and the tumor marker AFP, alpha protein, was elevated. So additional TACE was performed to control this lesion. Because this treatment became refractory 2 years after treatment started, we performed various subsequent treatments, and then the patient has survived for 4 years since the start treatment. This elderly man with HCV positive has been treated with multiple local therapy for recurrent lesions. However, it finally became refractory to treatment. Because of the large number and the diffuse type of the intrahepatic lesions, we were concerned that the disease was refractory to treatment. However, all lesions disappears at 3 months after treatment started, and this effect long-lasting. The other day, we performed CT scan for follow-up demonstrating no evidence of recurrence, and the patient has follow-up over 2 years without additional treatment. This patient was found to have 3 intrahepatic lesions in both lobes of the liver, one of which invaded inferior vena cava, and then we considered it unresectable. The patient started treatment, and then the IVC tumor thrombosis shrank so markedly after 5 courses that our surgeon recently performed a conversion resection. When such high tumor shrinkage is achieved, we may experience cases in which curative treatment can be performed after chemotherapy. A 75-year-old man was diagnosed as having a single HCC in the background of alcoholic liver disease and was referred to us. He was referred to the cancer board with the intention of resection, but there was a concern that the tumor had rapidly increased in size within a month compared to the previous radiological findings. And the tumor marker, alpha fetoprotein, was very high, but the surgery was scheduled for 2 months later. Therefore, we introduced lenvatinib plus cisplatin. Fortunately, rapid tumor shrinkage was achieved in one course of lenvatinib plus cisplatin. In this case, test was performed afterward to achieve good local control. Recently, it has shown that hike using FOLFOX before resection of resectable HCC prolongs OS compared with upfront surgery in China. Of course, a higher response rate is characteristic of this treatment regimen. In addition, the higher tumor rate is another feature. This is very important factor for neoadjuvant chemotherapy in terms of missed resection opportunities. A clinical trial is currently undergoing to evaluate the efficacy of this combination as a neoadjuvant setting in patients with borderline resectable HCC. This combination, which has a high tumor reduction and a tumor control rate, is expected to increase the resection rate and reduce recurrence when administered prior to resection. This is our treatment strategies for advanced HCC patients in our team. Basically, we select combination immunotherapies as first-line treatment. However, for part of patients who have high tumor burden or vascular invasion, we may select lenvatinib plus hike using cisplatin for tumor reduction. After the immunotherapy, we basically select lenvatinib monotherapy as standard of care as second-line treatment. However, we introduce clinical trial comparing lenvatinib and lenvatinib plus cisplatin if the patient meet inclusion criteria. A clinical trial is currently undergoing to evaluate the efficacy of this combination therapy as a later line treatment after immunotherapy for advanced HCC. We hope that better treatments will be developed for patients with advanced HCC from the result of this study. This is my conclusion. Lenvatinib plus hike using cisplatin is a well-tolerable and effective treatment for advanced HCC. And then, considering positioning of lenvatinib in era of immunotherapy, lenvatinib plus hike using cisplatin is expected to be applied to subsequent treatment after immunotherapy or preoperative treatment. Thank you for your kind attention.
Thank you, Professor Terashima, for presenting wonderful result of LEOPARD study and your institutional study result. How about the question or comment? Actually, I'm very impressed by the response rate of LEOPARD study. As you know, a response rate of monotherapy lenvatinib is around 20%, and atezolizumab treatment response rate is around 30%. But the combination of lenvatinib plus cisplatin is 46% response rate, and in his institute, 68% of response rate. And from this result, as he said, it is very good for neoadjuvant chemotherapy before resection. We have good response rate treatment, conversion rate may increase. But from your study, really first-line treatment should be combined immunotherapy, or sometimes, in my opinion, first-line treatment, leopard, cisplatin plus lenvatinib is sometimes better than immunotherapy. How do you think about it? Or how to distinguish which treatment is better for the patient?
Thank you for comments. I also think that first-line treatment or for advanced HCC is combination therapy, combination immunotherapy, because the primary endpoint for the advanced HCC patient is to prolong overall survival. And another factor is tolerability for the treatment. As you know, lenvatinib is inferior to atezolizumab or durvalumab for advanced events. So I think I recommend the patients basically immunotherapy for first-line treatment. However, some of the patients require the response. So for those patients, we recommend lenvatinib plus cisplatin hike, I think.
Because we have sometimes patient, if disease progressed, no second-line therapy. Such a patient sometimes we have, and in such a case, high response rate treatment is preferable. So in such a case, lenvatinib plus cisplatin is one of the options. And from these studies result, maybe it is a little bit attractive to use, I'm sorry for Eisai, but use, instead of lenvatinib, how about the use of atezolizumab plus cisplatin? New treatment.
Yeah. But I don't know the, and I have no rationale actually. Combination adding to cisplatin to lenvatinib, I have no result based on basic research. So we try to study the immune response, for example, in hike and lenvatinib patients. Or I want to some rationale to claim the efficacy of this combination therapy. As well, immunotherapy plus cytotoxic agent is maybe attractive, but no rationale. There are no rationale, so I don't know the result or clinical trial for.
Okay. I see. And also I'd like to ask you one more question about the indication. How about the patient with extrahepatic lesion? Because lenvatinib is working, so local regional treatment, cisplatin is better. It is possible to use for patient with extrahepatic lesions?
I try to this combination therapy for mainly in intrahepatic lesion. So we don't know the extrahepatic lesion, the effect for extrahepatic lesion adding to cisplatin.
Okay, thank you. Any more comment? Ikeda sensei.
Thank you very much for your propaganda of the Lempard nail trial. I'm Master Fumi Ikeda, National Cancer Center Hospital East Japan. So my question is predictive factor of the tumor responses of this Lempard regimen. So I saw a lot of cases of the response cases. So all cases is the tumor burden was very high. So this patient is a good candidate for the Lempard regimen. So how do you think about it? Indication of the tumor related factor?
Thank you for precious opinion, but unfortunately, I have no result. So I try to study the predict factor or prognosis factor of Leopard regimen. Thank you.
Okay. Thank you, Professor Terashima, for nice presentation.
Thank you very much.
So I'd like to move to the next presenter, Professor Kaoru Tsuchiya. You know well about her, but shortly I'd like to introduce her. She is now Director, Department of Gastroenterology and Hepatology, Musashino Red Cross Hospital. And she has graduated Gunma University in 1998, and from 2020, she took present position. And her topic is new treatment strategies for unresectable HCC, the positioning of lenvatinib in real-world practice. Professor Tsuchiya, please.
Thank you so much. Your kind introduction, Professor Kato. Good, good afternoon, everyone. It's a great honor for me to give a presentation at a wonderful meeting. I really appreciate Professor Ueno, organized committee, and Eisai. And of course, I really appreciated Professor Omata. And I apologize, my voice is not good, but I completely okay. So let's start my presentation. So I focus on the positioning of lenvatinib in the real practice. This is my disclosure. I have divided my presentation into 3 parts. At first, I present a new treatment strategies for patients, especially with intermediate ACC. After that, I show the real-world outcome of lenvatinib plus TACE at our institution. And finally, I will introduce the data lenvatinib after immunocombination therapies. Let's start new treatment strategies for patients with intermediate stage HCC. And today we can use 8 regimens for patients with unresectable HCC. The purple is the first-line therapy, and from 2020, we can use immunocombination therapy. The Professor Kudo proposed the goal of the BCLCB-HCC was clinical CR and drug-free using lentase or ABC conversion therapy. So I introduced the result of TACTICS-L trial. The TACTICS-L trial is a phase 2 prospective multicenter single-arm study performed in Japan. Its a TACE is scheduled. First TACE is scheduled, and lenvatinib was administered for 14 to 21 days prior to the first TACE. And after prior TACE, TACE was performed on demand. And this is the basement characteristics of the patient. So actually, the half of the patient was BCLC-A, and 54% of the patient was BCLC-B, and the patient beyond up to 7 criteria was 35%. It's a rare data. I think it's very important for the clinicians. So let me focus on the relative dose intensity of lenvatinib. So relative density of lenvatinib is very important in real-world practice. So before TACE, the median RDI of lenvatinib was 100%. But however, after TACE, the relative dose intensity of lenvatinib was only 47%. And the duration of lenvatinib is also very important. And after this, the median duration of lenvatinib was 10 months. So thinking about the result of the trial, we tried to give the lenvatinib to the patient on the full dose before taste, but after taste, we don't have to give the full of the lenvatinib after taste. And the duration of lenvatinib is almost 10 months. It's a PFS. The median PFS of the trial was 28 months, and overall survival, median overall survival is not reached. And this data is also very important. It's a subgroup analysis of the responders. So when we focus on the relative dose intensity of lenvatinib, so before first days, the maintain the full dose of lenvatinib was significantly associated with response or CR. However, the relative dose intensity of lenvatinib after first days was not significantly associated with the response or CR. So the relative dose intensity of lenvatinib was different between before taste and after taste. So it's the data of the safety profile. There is not so many grade 3 adverse events, and most of adverse events are manageable. I introduced the other lenvatinib plus taste trial. It's a launch study. The study was performed in China, and it's a prospective randomized control study on taste plus lenvatinib and the lenvatinib. The left side, you can see the baseline characteristics, and compared to the TAXIX trial, the patient in launch study was a very advanced patient. The 71 patient had macroscopic portal invasion, and almost half of the patient had extrahepatic split. On the right side, you can see the subgroup analysis. So importantly, the patient with and without extrahepatic metastasis, lenvatinib plus taste was the both better prognosis in patient with or and without extrahepatic metastasis. So we can perform lentase in patient with extrahepatic metastasis. So this slide showed the adverse event in the launch study. There is no significant, not manageable adverse events. So the clinical question is how to choose lentase or atezolizumab plus bevacizumab in real-world practice. To find the answer, I looked at data from the nationwide observational multicenter study of lenvatinib performed by Japanese Red Cross Liver Center Group. We collected the data, the patient treated with lenvatinib. The patient number was 343. The median age was 73, and BCLCP patient was 44%. So it's about survival and progression-free survival. So the patient with BCLC stage B, first line lenvatinib with very good liver function. In such patient, the median overall survival was 25 months, and the median progression-free survival was 1 year. We analyzed the prognostic factors in patients treated with lenvatinib. The factor is performance status, liver function, and tumor markers, AFP, and macrovascular invasion. And Dr. Tada at Himeji Red Cross Hospital already reported neutrophil to lymphocyte ratio, and NLR is associated with survival in patients with unresectable ACC treated with lenvatinib. The patient with higher NNR or had a poor prognosis. So he's Naoki Uchihara. He's my colleagues, and the presented the data, the morning session. We analyzed the factors associated progression-free survival during lenvatinib in patients with BCLC-B up 7 out. In first-line patient, in multivariate analysis, the liver function and CRP were significantly associated with PFS. So, thinking about the result, key factors for lenvatinib therapy in BCLC or in all patients is liver function, NNR or CRP, and performance status and AFP. If the patient has good liver function, low NNR and low CRP, and good performance status and low AFP, lenvatinib works and showed a really excellent prognosis. So let's move to the real-world outcome of lenvatinib at our institution. This data was made by Dr. Uchihara. He's a very talented young doctor. We are happy to work with him. And the patient number was 31, and we classified the patient into 3 groups. A group was performed tests to achieve CR on demand. The B group is to perform tests to achieve PR or CR on demand. And C group is we schedule tests and lenvatinib started before tests. It's a tactics method. You can see the baseline characteristics. And group A and group C, all patients are BCLC-B patient. This slide showed OS and PFS. The median observation period was 17 months, and the median overall survival was almost 14 months, and the median PFS was 22 months. And this slide showed overall survival according to BCLC stage in Group B. Group B means to perform tests to achieve PR or SD on demand. So in patient with BCLC-B, the median overall survival was 41 months. One of the good reason of the perform the lentils is we can perform sequential therapy after lentils. Only 3 patients moved to the best supportive care, and most of the patients could receive the other molecular target therapy after lenvatinib plus TACE. I can show one case, and he's a 70s male, and background liver disease, alcoholic, and good liver function. And the first therapy is resection. But after 1 year after the resection, he had a multiple recurrence bilobular. But his liver function was preserved, and he had low AFP, so we decided to lentils. So it's the group C was scheduled TACE, and we started lenvatinib before TACE, and it's a full dose of the lenvatinib. So after TACE, we could modify the lenvatinib because RDI of lenvatinib was not significantly associated with the responder or CR in tactics L trial. And we stopped the lenvatinib because she achieved the clinical CR, and we only observed now. So let's move to the lenvatinib after immunocombination therapies. So it's a JSHA guidelines already presented by Dr. Terashima, and we can perform the two types of the immunocombination therapy as first line. So Dr. Aoki at Kindai University already reported the lenvatinib therapy in patients with who failed to the first-line immunocheckpoint inhibitors. It's a result of the study. The median PFS was 10 months, and lenvatinib after checkpoint inhibitors and relatively good treatment result. The next, the other study is heritage study. It's presented by Professor Asaoka at ASCO GI. And from 2020, we Japanese doctors use atezolizumab plus bevacizumab as first-line therapy. The point of the second and third line, after atezolizumab plus bevacizumab, we Japanese doctors often use lenvatinib after atezolizumab plus bevacizumab. And the DCR was 80% with RECIST criteria, and median treatment duration was 87 days. So it's a multi-center study, international multi-center study. The patient number was 464, the atezolizumab plus bevacizumab, and the data of the second line therapy is 233. It's about survival from the beginning of the second line after atezolizumab bevacizumab. The patient who received lenvatinib after atezolizumab plus bevacizumab, in such patient, the median OS was 17 months, and lenvatinib has significantly better prognosis compared to the other TKIs. And it's data from our hospital. The patient who received atezolizumab plus bevacizumab as first line, we use the lenvatinib as the second line. And induction rate of molecular target therapy and 77% in atezolizumab plus bevacizumab. So we use lenvatinib after atezolizumab plus bevacizumab. The patient number was 23. And the median age was 73, and this is about survival in lenvatinib therapy from the end of atezolizumab plus bevacizumab. The median overall survival was 15 months. The best response according to the, we focus on the proteinuria. The UPCR over the more equal or more than 2 is unfortunately there is no objective, no patient who could achieve ORR. However, if the patient with low UPCR and ORR was 25% and DCR was 87%. And we collected data on the second line lenvatinib after atezolizumab plus bevacizumab. The patient number was 54, and according to the RECIST criteria, ORR was 17% and the DCR was 72%. And we focus on the, again, proteinuria. So the patient with the less UPCR, and according to the latest criteria, ORR was 20% and DCR was 73%. However, if the patient with high UPCR and severe proteinuria, so ORR was 0% or MLS only 17%. So I think the management of proteinuria during the first-line therapy, atezolizumab, bevacizumab, is very important for the, of course, very important for the first-line therapy and also important to the sequential therapy. Let's move to the steroid regimen. We performed the steroid regimen in 21 patients. The most of the patient was BCLCC, and 81% of the patient was BCLCC. There is a logical response of the steroid regimen. The patient who received the steroid regimen as first line to as third line therapy, the patient number was so small, but the ORR was 22% and DCR was 66%. It's similar to the Himalaya trial. So we performed the subsequent therapies after the steroid regimen. So, and the sorafenib, cabozantinib, and lenvatinib, the other molecular target therapies. I showed one case, and the patient is 60 male, and the first line therapy, first therapy is initial therapy was radiofrequency ablation, and unfortunately, after 3 years, the patient showed a peritoneal metastasis. So we started sorafenib, regorafenib, atezolizumab, lenvatinib, cabozantinib, and this year we started the steroid regimen. This slide showed a clinical course, and the patient once achieved the stable disease by steroid regimen, but after 4 months, the disease was progressed, and we restarted the lenvatinib, rechallenged the lenvatinib. So AFP was decreased after the initiation of the lenvatinib. And Dr. Hagiwara already reported the improved tumor response, the lenvatinib rechallenge after the immunocheckpoint inhibitors. And so the second line after the immunization therapy, there is no evidence or big data. And TKI would be key agent after first line immunotherapy. In conclusions, lenvatinib showed certain effects outcomes in real-world practice. Liver function, performance status, NLR therapy, and AFP are carefully evaluated in BCLCB treated with systemic therapy. So we can choose lentase or atezolizumab based on the data. So lenvatinib is one of the key agents after first-line immunocombination therapies. Thank you for your attention.
Thank you, Professor Tsuchiya, for excellent presentation using own data. Any comment or question? As you said, lentase is a very attractive option for the patient. But which is better, do you think, scheduled TACE or on-demand TACE after lenvatinib treatment?
Thank you for your question. Actually, if we can, the scheduled TACE, the taxol is very attractive because the patient, according to the result of the taxol trial, the patient only received lenvatinib at 10 months, and we can stop the systemic therapy. Yeah.
Okay, scheduled TACE is sometimes preferable than on-demand TACE, but also I'd like to ask you, you have mentioned that after IO treatment, second line lenvatinib treatment is very effective. And also this is in our institute, the same result we can get But now we have another option of IO, namely durvalumab tremelimumab. So position of lenvatinib is change or no change. For example, first line IO, still second line is TKI is better. Or after the combined IO treatment, the second line treatment IO is possible. How do you think about which sequence is better, IO TKI treatment or IO treatment?
Thank you for your question. I think there is not so many data after the first line immunocommunity, but we have the data, the nivolumab plus ipilimumab after the second line therapy, and the response rate ORR was nearly 20%, and the data is not so excellent compared to the second line lenvatinib. So I think we can choose the lenvatinib or other immunocombination therapy based on the patient situation. If the patient had a severe proteinuria, we can choose the
that's right,
immunocombination
yeah.
therapy.
Thank you. And any comment or question? Okay. Still, we have a little bit time, so any question or comment? My last question is very interesting case of re-challenging lenvatinib. That's a very attractive option for the patient. But still, now we have, as you know, 8 regimens. So after using all the regimens, re-challenge sometimes we have to do so. But before using all the regimen, when we retry the same drug for the patient after PD?
Thank you for your question. To be honest, I didn't like the challenge,
Okay,
but because as you said, we can use 8 regimens, but the Dr. Ueshima and Professor Kudo at Kinda University showed the data of the re-challenging of the lenvatinib, and they told me that the point is the first response of lenvatinib. The patient who have the good response at lenvatinib as first line, so first line or the initial lenvatinib of the response of initial response was good. They tried to re-challenge, but the patient didn't respond to the lenvatinib. They didn't re-challenge. It's I think it's reasonable.
Thank you, Professor, for Tsuchiya, for a very instructive presentation. Thank you. So now the time has come, so I'd wrap up this session, Luncheon Seminar 1. Thank you for all audience and also Eisai Company for giving us such opportunity. Thank you.
Thank you very much, Chair and lectures. We'd like to kindly ask you to bring the empty lunch boxes to the exit and hand it to the staff. Thank you.